Good morning, good afternoon, or good evening, wherever you are in the world. Greetings from Australia, Baltimore, Switzerland, and Canada, Toronto, Canada. Really excited to welcome you all to this really different and quite exciting session that we have planned for you now. We have some of the world's most prominent and experienced speakers, and I think you'll really enjoy this session. My name's Santrain Pasricha. I'm a researcher in Melbourne, Australia, and I'm really pleased to be joined by all of you wherever you are today. So what are we going to talk about today? I think let me just spend a couple of moments framing our session for you. I guess we all know this website. This is where we look for guidelines to help us understand what type of interventions we should be considering and providing to the populations that we serve, or trying to understand what type of research we need to do next to advance the field. And this is just one of many clearinghouses for guidelines in global health and in medicine around the world, but I think perhaps the most prominent in our field. And if you just take any one of these at random, you'll see that there are detailed recommendations and advice about what we need to do. But I guess the question we have is where does this information come from, and are we and how does this all the knowledge in the world get put together to allow us or allow the guideline makers to make these recommendations? Many of you may have come across the World Health Organization Handbook for Guideline Development. Actually, I think that it may have actually been updated since this last one, but WHO want to make their recommendations to be, they require their recommendation to be based on the best evidence available, and that's a very noble ideal. And so their recommendation is that one would use a systematic review to develop the evidence, and that if conducted properly, they reduce the risk of selective citation and improve the reliability and accuracy of decisions. Many of you will be familiar with the hierarchy of evidence. So expert opinion, which is just you ask someone something and they tell you what they think. Well, this is no longer really considered enough. And indeed, observational studies are still towards the base of this hierarchy, and it's the randomized controlled trial and then the systematic review of randomized controlled trials that sit at the peak of the hierarchy of evidence of what we need to trust most. And when we put our information together, WHO uses a version of this, and many international guideline makers around the world in clinical medicine as well as in public health use similar approaches. We need it's important to be able to characterize whether the quality of our knowledge and how confident we are that the evidence that we have and the information that we have actually reflects the true effect, and whether it's very low and that we can have very little confidence, all the way up to high, that we're confident that whatever we think our evidence is, that we're confident that estimate really is likely to be accurate. But of course, there are many ways to get there. So this is a systematic review that I did back some time ago, and this systematic review was looking at the effects of iron interventions in babies on child development. And I did this systematic review, and and there were a few studies in it, and I made a forest plot, and I was very proud of myself, and we published that. But what's interesting is when I counted it up, there was, let's count them now. Actually, I haven't counted before this talk, but that's one study actually combined. There's 1, 2, 3, 4, 5, 6 studies in this particular meta-analysis. And then I realized there are actually more systematic reviews of the same question than there are the trials that are included in this particular systematic meta-analysis. So in fact, there is definitely a saturation of systematic reviews compared to the number of trials. And so I was really wondering which one takes us further. I mean, how many times can you look at the same question in a slightly different way, or do you? And given that this was inconclusive, not surprisingly, these were inconclusive. So I thought that was really pretty interesting. And so indeed, we have these systematic reviews, we have these competing, slightly different perspectives. And of course, once the systematic reviews get into town, things can really get pretty rough. But of course, systematic reviews are not the only way to make knowledge, and not the only way to bring information onto the table. In fact, many of you may be aware that actually, even last night, that there was some initial reports on some very exciting news on the coronavirus vaccine from Pfizer, and that, you know, it was just very early information. But what they're doing now is their big phase 3 clinical trial. In fact, I've got to say, there's probably never been a better time in the world that people know what a phase 3 clinical trial is. So there's thousands of patients on these phase 3 clinical trials of these different drugs. Now, when they get past this, there may be systematic reviews that get done down the track, but they're going to take their drug to licensing, or they're going to take their vaccines to licensing, and they'll get those approved. And then if the FDA or the regulators approve them, they'll go into patients. So that's a really different way of seeing the world, of doing your clinical trials program, getting your drug licensed, and then getting it into people, not waiting for another phase 3 trial or lots of phase 3 trials, putting them together in different ways, and then doing systematic reviews. So there are different, and I really just show this to say there are different paradigms, different systems for making knowledge that is influential on people. So the question is, that for today's discussion is, how do we go about making our knowledge? How should we do it? What's the best way? Do we continue to do, or should we rely on the systematic review approach, which in my experience can take many years? Actually, I've done some randomized trials and I've done systematic reviews, and it doesn't actually take that much difference in time sometimes, but ideally it should be a bit faster. They're relatively cheap. They're usually post hoc. Sometimes they're pre-planned. But there's a systematic review approach. Or if we have a killer question, should we be really just moving on to the randomized control trial and addressing that question? But of course, these can take a long time as well, a very long time. They're usually pretty expensive. They can cost millions of dollars, and you can just do one experiment at a time. So this is going to be the point and the focus of our debate today. And so we have 3 speakers who in some ways really need no introduction, but I'm going to introduce them anyway. First, we have Professor Zulfi Bhutta, who's going to speak to us from the Hospital for Sick Children in Toronto. And he's also the co-director of the Sick Kids Center for Global Health, and also a professor at Aga Khan University. His research interests include newborn and child survival, maternal and child undernutrition, and micronutrient deficiencies. He's probably done more randomized controlled trials and systematic reviews than really many of us, probably a lot of this audience combined. And really, there's no one more expertly qualified to speak to us today. And he will speak in favor of the argument in favor of systematic reviews. Then we will have Professor Keith West, who is the George Graham Professor of Infant and Child Nutrition at the Department of International Health at the Bloomberg School of Public Health and Ophthalmology at Johns Hopkins University in Baltimore. Professor West has worked extensively in many countries around the world, in Asia and Sub-Saharan Africa, on micronutrient deficiencies in clinical trials. And he will speak in favor of the value of randomized controlled trials. And finally, as our discussant, after we've heard from both of our speakers, will be Dr. Lynette Neufeld, who is the Director of Knowledge Leadership at the Global Alliance for Improved Nutrition. And she is both a generator of knowledge as well as a user of a lot of the knowledge that is made by academics around the world. And so she'll provide her perspectives and discuss our findings. Now, the way that we'll run this session, in a moment, I'll hand over to Prof. Bhutta, who will speak in favor of his argument. We will then cross over to Prof. West, who will speak in favor of his argument. There'll then be rebuttals for a few minutes each, and then we'll hear some discussion from Lynette. And then, most importantly, we're looking forward to receiving lots of questions for discussion from you out there in the audience. Now, I've already briefed the speakers, and there's plexiglass between them, and we have the mute button. So if they're interrupting too much, we know it'll be okay. But thank you very much for all of that, and I'm really looking forward, Prof. Bhutta, to your talk.
Thank you very much, Santa, for that wonderful introduction. And I'm delighted to be speaking to you today. And just to qualify, all our plans to get a real debate and some discussion between Keith and I was absolutely laid to waste by the US elections. So none of us have seen what the arguments or points of the others are. So it may be that we may end on the same side of the argument. So I am going to speak to systematic reviews and randomized trials, but with a nuance as to what we need to do when we are confronted with this. So some disclaimers. I mean, yes, Santa said, yes, I've spent a lot of time on both doing systematic reviews. I lead large groups doing this, but I've also spent time on doing large-scale cluster randomized trials. And therefore, the views that I'm going to express today are largely my own, and they have nothing to do with either my collaborators or the Campbell collaboration that I've had the honor of chairing the nutrition group for. You've already seen the slide on the hierarchy of evidence. This is nuanced slightly from what Santa presented. Yes, we do think that randomized controlled trials are very important, but increasingly we are beginning to recognize that within that hierarchy of randomized controlled trials, there are the types of studies, the types of real life effectiveness trials that have special value, and that they move you from the proof of principle kind of studies to what really works in real life. And then again, in these systematic reviews and meta-analyses, there are types of meta-analyses that allow you to understand the context and some of the questions a little better. And I shall be speaking today about individual subject data or patient data IPD analyses, which have been really helpful in trying to understand some of the findings and sometimes counterintuitive findings of trials. So there has been an exponential growth in randomized controlled trials and systematic reviews over the years. Just taking this particular graphic, from the time when we first recognized the importance of systematic reviews and did the first Lancet series on this in 2008, between 2008 and 2013, when I did the next set of overview analyses, the field had grown about threefold. You can see that from the number of trials. But as we have looked at this recently as part of our forthcoming Lancet Nutrition update, the field has just exploded. And in order to get a sense of the evidence, we had to go through something like 3,500 systematic reviews to get some sense of what was happening. And therefore, a very important task for policymakers as well as researchers is making sense of all this information, not only in the information that can be synthesized in a really meaningful way, but the translation of information into knowledge and in turn into wisdom. So no wonder about a year ago, Richard Horton in the Lancet highlighted the issue of the gravy train of systematic reviews. And he did that on the basis of things that had been written a few years ago by Ian Roberts and Catherine Kerr, who looked at this systematically and pointed out the issues with systematic reviews if you were not careful in terms of including all kinds of information in this. So one of the reasons that there's been an exponential growth in systematic reviews is that it's so easy to do them. You not necessarily register everything in Prospero or in the Cochrane or Campbell libraries. You can go ahead and do it, and oftentimes, unless somebody points out, you can get away with publishing it somewhere. And then in the desire to add additional information to get the largest number of studies in, people add all kinds of studies to systematic reviews, and they are therefore of variable size. So what Ian and Catherine pointed out was the unreliability overall of relatively small single-center trials, which would raise concerns about the value of those to the overall enterprise and to the overall synthesis of knowledge, where you were not only comparing apples and oranges, but you were comparing watermelons with grapes. And that's an important part to recognize in terms of some of the issues that we understand in systematic reviews, the issues of duplication, and yet the importance of replicating some reviews where the questions are important, but done in a scientific manner, pooling contextually different studies, and importantly, when is it enough? So as was pointed out, I can tell you for the multiple micronutrients, there are actually about 10 more systematic reviews than there are studies, and they are growing every year. Poorly sized and designed trials that should not be included in the first place. And then the whole issue of data veracity, which is a big gorilla in the room that we don't talk about. And it only really becomes known once you get to raw data. And Individual subject data analyses allow you the importance of looking at data quality checks through that one-step process where you look at the information itself with metadata, and that has generally not been done with systematic reviews to date. And finally, I'll say a few words about efficacy and effectiveness studies. So let me try and see if I can illustrate some of these thoughts through some illustrative examples. And as was originally billed, let me start with some issues around the evidence on zinc supplementation, something very close to my heart. So some 20 years ago, or thereabouts, Ken Brown and team first highlighted the importance of zinc for growth in childhood. And they looked at this through a range of publications, of which a seminal one was this meta-analysis of randomized controlled trials. And what Ken and colleagues identified was that overall, despite the variation and diversity, there was a positive effect size for height with zinc supplementation. And if you looked at various drivers or determinants, it appeared to be greater in children who were more stunted at baseline, who were also more wasted, even though the effect size was quite dispersed, younger, and those who had relatively lower serum zinc concentrations. Now, fast forward to some 12 years on, when we looked at this through the lens of the Cochrane review process, some of the evidence seemed to be amenable to perhaps a more disaggregated analysis. And what we therefore ended up in that review was to exclude children who were not well, hospitalized, severely malnourished, and who had chronic conditions or diseases. And here you find that the effect size that we discovered in terms of impact on height was much lower than what previous studies had determined. Fast forward further a few years, Liu and colleagues from Wafai Fawzi's group looked at this a bit further, focused in children under 5, and also excluded supplementation studies where the duration was much less than 3 months and where they did not report on the dose given. And they found that there was a significant impact on height, larger than what we had seen in the Cochrane review, and also on the height for age z-scores. More recently, when we looked at this ourselves, after the discussion with the Lancet in terms of how we would like to parse out the evidence, we decided to be a little bit more restrictive in terms of both looking at relatively recent studies that were registered formally, excluding very small trials, those that were clearly in children who are ill or specifically recruited based on conditions such as being low birth weight or stunted a priori or anemic. And here the universe of studies that you could review and put together shrunk. And what we found in this is that, well, while there was an impact on height per se, the moment you got to height for age z-scores, we lost the evidence in terms of benefit on linear growth that was evident in previous studies. But also note that the number of studies has shrunk considerably. Now, why did the number of studies shrink? It shrank because of a range of things in these two particular reviews that I compare. Firstly, we excluded older studies that were not registered prospectively, but were perhaps in a different context, and we can come to that in a minute. Those that were for high-income settings, those that were in newborns or in school-age children, which are not our focus, those that had been provided with additional micronutrients. So it was no longer an effect of zinc alone, or those that were related to unhealthy populations. And when you do this, quotes and quotes, so-called healthy populations or children who were not selected on the basis of prior problems did not have a significant impact on linear growth. Whereas when you went to children who had nutritional disorders, as you see in this forest plot, there was a significant impact on linear growth. So the point is context matters, and it really matters what evidence you are putting together. And therefore, increasingly, systematic reviews need to focus much more on the question at hand rather than the historic question, which may no longer be relevant. And a case in point is that of vitamin A supplementation. So when we looked at this some years ago, in our first systematic review on this, wasn't the first one. A number of really first-class seminal reviews had been done in this field. Despite the fact that we had relatively large studies, such as the DIVTA trial in here, which was actually a programmatic evaluation, we do see that there is still an all-cause mortality effect at the longest follow-up, about 12% reduction in under 5 mortality. But when you parse the data out in terms of changing context, and you look at pre-1995 studies to those that were later, you do see that there is a dampening of effect. And that dampening of effect and the non-significant findings on mortality post-1995 probably represent changing context in terms of prevalence of vitamin A deficiency, existence of programs, as was said in the previous section, and therefore, in asking the question and answering it in today's context, you've got to take into account things like prevalence rates of vitamin A deficiency in mothers and children in today's world. Perhaps the most illustrative example that I can give you is from our recent work on the big question of deworming. Does deworming work? Billions of dollars being spent on this every year in school-age children or preschoolers as a program that is based on solid belief systems, both at the level of government programs and at the level of WHO as to how these soil-transmitted ailments affect health outcomes. And they include both the standard gut worms as well as things like schistosomiasis, which can cause significant anemia in addition. The numbers are impressive. You've got about 1.5 billion people in the world infected, and you can see this both in terms of prevalence rates and population proportion infected. And you'll see this largely in South Asia and parts of sub-Saharan Africa. The problem arose because a Cochrane review, a much cited and important Cochrane review by the Liverpool group by Paul Garner and colleagues, actually looked at the question of impact on health outcomes. And I'm going to show only one of those that's been of interest to people. Let's say linear growth. And they demonstrated that from the data that they had seen, that there was virtually no effect, or at least not a significant effect because it exceeded zero. And therefore, they made the recommendation at that time that these programs should be reviewed in terms of their global relevance. We followed this with an IPD analysis, but that was largely a two-step process. We did not look at a lot of individual subject data. This work led by Vivian Welch and colleagues looked at effects on height, weight, and impact on stunting. And we could not convince ourselves that there was an impact on linear growth. And this was clearly followed by a lot of debate, the so-called worm wars, as to whether or not our premise and our conclusions were justified. And this was also associated with a very famous replication study done by colleagues at the London School of Hygiene and Tropical Medicine, which could not replicate the findings of the original trial. So we undertook a large IPD. We spent 2 years doing this by going through the entire database and potential studies to bring into this. And altogether, what I can show you is that of 41 eligible trials, we were, after 2 years of effort, able to get 19, which almost were 79% of the randomized children. So it immediately tells you that the vast majority, 22 of the 41, only represented 21% of the entire children randomized. These studies that we could not get, and if I can go back to the slide for a minute, were those studies that were relatively old, smaller, but with much larger effect sizes. What we ended up by looking at with these almost 80% of the data across the globe in terms of studies through this network meta-analysis that we were able to simplify was that on average, the effects on nutritional status and cognition at a population level was small, with only a moderate amount of uncertainty. And there was a small amount of effect on weight, but nothing on linear growth, and almost nothing on hemoglobin, except in studies where micronutrients were given in addition. So our conclusion was that the effects of deworming were uncertain in children with heavy intensity infections. But as I mentioned, we were handicapped by the fact that 21 studies were not available and that many refused to share the data with us. We could not convince ourselves in terms of a relationship between year of publication and impact or hookworm prevalence on either weight gain or for either hookworm or ascaris. So it's difficult to say if this is related to secular trend, but it just tells you that one needs to have adequate storage of information, particularly for studies that were relatively recent. This is also an important point for me to pivot and tell you that we need to somehow or the other bring in larger studies where the confidence levels may be greater in terms of effect. And brings me to the deworming part of the DEFTA trial in India, which was as I said, possibly a cluster randomized program evaluation where close to 1 million preschool children were evaluated after 6 months treatment with albendazole. And it's a pretty complex study, but compliance was good, 86%, and both prevalence rate of deworming of worms in a subset, close to around 5,000 children, overall mortality, and importantly, impact on nutritional outcomes were assessed. So on mortality, there was no effect on mortality. We can put that aside. But in terms of weight gain, despite this huge exercise, there was negligible impact on weight gain and non-significant. And it therefore appears that this large real-life evaluation effectiveness trial, some or the other, ought to have much greater relevance in terms of the context of deworming today. But given the systematic reviews, it doesn't, because it's just one of many studies included within this. The same can be said to the story for zinc. I undertook a large cluster randomized trial, in fact, the largest to date in this space, with the real health system is using public health programs in Pakistan with daily zinc and micronutrients on growth and morbidity amongst young children. This is a complex 3-cell design with close to around 250 clusters randomized to this, and around 2,100 children who were evaluated at the end. And to cut a long story short, apart from the other findings of this trial that I shouldn't get into today, you see absolutely no impact on linear growth of providing an extra 10 milligrams of zinc to these children over an extended period of time in comparison to controls. As I conclude, I think it's important to recognize that we need to bring additional information in, over and beyond just the quantitative aspects of randomized controlled trials. And some of the best studies evaluated in these regards are studies that have come outside of the field of quantitative meta-analysis. This is a recent paper by Naila Kabir from the London School of Economics, who has looked at 2 large poverty reduction programs in Bangladesh and Pakistan, and looked at the relationship of her own assessment, qualitative assessment, on the empiric findings and methodological reflections. And what she concludes is that pure randomized controlled trial-based assessments of outcomes may not be sufficient, and that a greater use of mixed methods would help offset some of the limitations that you have in RCTs of understanding the direction of travel and how things changed. And I'd like to use that to make some concluding remarks. Firstly, systematic reviews of high-quality randomized controlled trials of appropriate quality design should remain the gold standard for information for guidance. However, many of these systematic reviews do not sufficiently adjust for context, trial size and quality, and fewer still for time trends or secular trends. These are critical to make sense of the evidence. And I do think that we somehow or the other need to give greater weightage to the scale and effectiveness trials within systematic reviews to assess benefits in real-life evidence using mixed methods. And this cannot be done by a simple quantitative weightage process in forest plots or meta-analyses. I also think that there is a real issue out there, and that in the spirit of openness and data sharing, open access to metadata should become the norm, even outside of IPD analysis. And I worry when people are not willing to share information, and I'm glad that at least Gates Foundation and the Wellcome Trust has made it possible after a certain time limit to have these data available for others to replicate and to include those in secondary reviews. So how does this relate to the question at hand? We need to inform the current existential evidence with increasing use of complex and real-time evaluations, which use a combination of what we know from systematic reviews and what we know from trials, with much more real-life experience on what is known through additional quantitative and mixed methods analyses. And more on this on Wednesday, when we talk a little bit about this in our stunting exemplars work. So ladies and gentlemen, I'd like to finish by just citing from one of my favorite economists. And Sir Angus Deaton, who's at Princeton, says, RCTs can play a role in building scientific knowledge and predictions, but they can only do so as part of a cumulative program, combining with other methods, including conceptual and theoretical development, to discover not what works, but why things work. Thank you very much for your attention.
Thank you very much, Prof. Buddha, for that performance. It was like watching a maestro playing their violin. Whilst you're just waiting for Prof. West to put up his slides, I'd just like to remind you all to start thinking about your questions for the discussion in a few minutes' time, so we can dig into some of these points. So, Dr. West, looking forward to hearing your talk.
All right, well, thank you very much. It's really a pleasure to join everybody globally today and to be on this program with my esteemed colleague, Zulfi Bhutta, and a very tough act to follow. However, we've been given topics. We did not see each other's slides. We wanted to outperform other debates that people may have seen elsewhere in this era, in this past few months. And so my title is Generating Evidence via RCTs, Avoiding Global Estimates That May Be Relevant Nowhere. And we have this "mine is better than yours" meme. And so, let's see, I'm trying to advance my slide here. Whoops, there we go. It really is mine is part of yours. Because one cannot carry out systematic reviews without high quality randomized trials that give rise to the evidence. My conflict of interest statement for the different kinds of support that have helped me in my research over the past years. And I'm presenting this perspective from that of a field worker. I got my research teeth on a 26,000 child trial in northern Sumatra in 1982 to 84. That was the first large micronutrient trial that showed an impact of semi-annual vitamin A supplementation on child mortality, reducing mortality by about a third. It was a time before Google Maps. And I won't tell you the kinds of computers we used, but I worked with Al Sommer and some wonderful Indonesian colleagues, Ignatius Tarwojo, Eddie Janetti, Bob Tilden, and many others, in carrying out a trial that made vitamin A come alive in terms of a potential child survival strategy. And learned a lot about the complexities and the challenges, the approaches to carrying out trials right from that time onward. Some initial thoughts, though, are that RCTs have a rationale and a critical role in assessing micronutrient interventions that are feasible, affordable, and can be scaled up if they turn out to be efficacious. The systematic review, often with meta-analysis, as Zulfi has pointed out, is really well established. It's transparent, it's scientifically rigorous in aggregating these results, as long as the trials are in areas of comparable risk and have designs that can be combinable. However, also, as Zulfi has pointed out, we'll find some points of contrast here, that there may be the inclusion of inappropriate studies and lack of consistency in drawing conclusions. There are also a point that I want to bring out is that the interpretive guidelines that can arise from systematic reviews may clarify, but they can also confuse. And if we think about doing trials that are aimed at providing evidence for generating the necessary base for making decisions about policies, then clarity is of the utmost importance. In particular, it's been my experience over these past short 3 to 4 decades of doing trials that a global estimate is not always relevant everywhere, and that there needs to be much more work toward regionalizing and specifying conditions under which the effects of trials can be taken forward into policies. And there are opportunities for what I call galvanizing guidelines. They're rare because you rarely find enough evidence to drive a policy, drive the scientific evidence into a policy arena, have it debated, and have it reach scaled up conditions. And so it's important to recognize when that opportunity avails itself. I would also say that it's imperative for our scientific community to read, interpret, consider, and act on findings from RCTs that are in settings that are relevant to our community, wherever it may be. And there's Latin America, Caribbean, there's Sub-Saharan Africa, Southeast Asia, East Asia, that we as a community read the original trials. Is a point that I would like to make and stick with in this presentation. To not rely completely on systematic reviews and to rely on good analysts, but people who did not do the trials, except for Zulfi, in interpreting and understanding the sensitivities and the intimacy that is needed to understand how trials are done in a particular area and what those findings actually mean. And so there should be regional weighting, which means regional weighting of the risk factors that aggregate from one region to another in making decisions about programs that should or should not go forward in a particular country. It brings up a couple of thoughts around the dilemma that we face in translating complex science to complex societies for policy wise. And it reminds me of Occam's razor, a 13th century philosopher, who said plurality should not be posited without necessity. And the simpler of the explanations of an entity are the preferred ones. And so simplicity is paramount for moving complex science into a graspable policy environment and for action. And then we have Einstein's attributed aphorism that everything should be simple. Everything should be made as simple as possible, but no simpler. He actually didn't say that. This was his actual statement, that it can scarcely be denied that the supreme goal of all theory is to make the irreducible basic elements as simple and as few as possible, without having to surrender the adequate representation of a single datum of experience. And so that pretty much failed the impact test. It resonates with scientists, but we have something to learn here. Everything should be made as simple as possible, but not simpler, is a far more compelling statement that captures the essence of what Einstein was getting at. And so we are between this rock and hard place. We deal with complexity, we look for simplicity, and at the same time, we shouldn't get so simple that we obscure the details that are needed to make informed decisions. We have to realize and remember that every RCT is carried out in a specific context. And EPI 101, we know that malnutrition, micronutrient deficiencies are distributed by person and place and time, and that the risks are affected by the agent, the diet, the host factors, and the environment that forms the habitat of this complex biosocial environment that we call society. And those factors that are relevant to a trial are carried into the decisions that need to be made about programs to do something about the problems that arise and the solutions that sometimes come from the conduct of trials. And so here's another triangle, the strength of the triangle, and a slightly different hierarchy of action that often guides how I think, where there's biological research across the nutriture, molecular, disease mechanism landscape, and that information is is communicated, not always in a unidirectional way. Frequently goes the other way, but it's combined with RCTs and randomized controlled community trials, which I emphasize because that's the hammer that I have had in my hand over the past decades, supported by the epidemiological evidence that can come about and be aggregated with systematic reviews. You should never do a trial without a thorough review of the literature, both the observational and what has been done prior to that in terms of interventions. So the trials are done, and that can lead occasionally to galvanizing recommendations that lead to policy pilot programs with implementation research that can ultimately pierce its way up through this triangle to attracting sustained resources, action, and ultimately prevention. And there is interaction across all of these levels. There is a constant flow that is captured sometimes by the systematic reviews. It's also reflected in the conduct, the design of the trials that actually get done. And so from the mechanism through the trials, we are dealing with biological complexity, trying to take the complex human biology and how nutrition affects it, and arrive at statements about what an intervention can do to a population's health. And from there, to move it into prevention, we're dealing with societal complexity as a broad term that reflects all the resources, the politics, the funding, the competing resources, the scourges that affect society, that can affect programs moving forward and so forth. Very complex, but ultimately we are dealing with the need to make decisions about relatively simple programs when we deal with all the complexity. And in public health, it's our job to understand the complexity, but when it comes to suggesting or arguing evidence for a policy or a program, it needs to be brought to a level of simplicity that is not too simple, but simple enough to go forward. Occam and Einstein. So I'd make a few comments about some of these kinds of issues in micronutrient deficiency prevention that Zolfi has mentioned. I won't say anything about zinc because I knew he was going to say something about zinc, but I wanted to put it there because it's obviously a critical micronutrient. And so here's a bar graph that reflects the impact of the Aceh study that I first worked on in Indonesia back in the early 80s, showing this impact of vitamin A on child mortality. And I'm bringing up this particular example because it was one of the first, if not the first, attempt to do trials, aggregate the evidence, come up with a coherent policy, and see that policy move forward. And so after that trial, there were a number of trials. Another one which I was involved in Starlai in Nepal in 1991, but a number of others that largely supported the effect of vitamin A in reducing mortality. These trials were then meta-analyzed, the first meta-analyses in micronutrient deficiency prevention by Jim Tinashe at the Bellagio conference in 1992, by George Beaton for the Hidden Hunger Congress, and George McCabe. And Wafai Fauzi published a wonderful meta-analysis of both the community trials and the measles trials in JAMA in 1994. And so there were convergent meta-analyses that, depending on what was included, the effect estimate was 23 to 34%, which was an early sign that depending on what the inclusion criteria are in systematic reviews, meta-analyses, it's going to affect to some degree the impact that one sees from efficacy trials that form the upper bounds of programs. Talk about this later, maybe in the question and answer, but I am a firm believer that program evaluations should never be combined with randomized control trials that have very specific criteria, very rigorous procedures for counting and for the conduct of a trial. And you should not combine the two. And that could be a point of arguing later on. But these were diverse studies. They were different delivery mechanisms, but they were adequately designed and powered to make a statement about the impact of this intervention on child mortality. This is an example of a statement. There was a meeting in Bellagio in 1992 with the express purpose of bringing investigators together to combine the evidence, discuss the strengths and weaknesses. And so investigators were not shut out from the process. They were brought into the process. And there were basically just 8 points that came out from trials that had 165,000 people about vitamin A being essential for health. Its deficiency is associated with increased mortality, that you can improve survival with vitamin A interventions, that as an example, the biological plausibility, measles was mentioned, but the severity of other infections that can be lethal were also mentioned, that it had an impact on the indicators. Interventions, vitamin A supplementation or fortification had an impact on the indicators of vitamin A status of a population to show that there was a nutritional effect that was intended. And that there were, the extent of the problem was brought forth, tens of millions of children, and that this is a potential child survival strategy. And it was all contained in one brief that went out across outlets throughout the world, in the journals and magazines and different journals. We didn't have the internet at that time and the social media that exists, but the idea was there, the effect was there, and it led to vitamin A supplementation being ramped up in over 80 countries around the world and saving likely tens of millions of children's lives. Over time, there have been this was based on 8 studies. Over time, there have been 39 more studies added in meta-analyses that have been carried out. And in deference to my good colleague, Zulfi, I would say that, that those additional studies, that most of which were not designed to address mortality, have added really very little to the basic evidence base from the trials that were carried out. And that the studies that are after 1995 or 6 that have been identified, one was a program evaluation, the DEVTA study, that should not be, in my opinion, in that cluster of evidence. Just a couple of other comments. Newborn vitamin A is another important factor because we're talking about life-saving interventions, and this is the map of where the newborn vitamin A trials were carried out. And if you go to mygeocenter.com, you can find the geocenter of all of these trials, and it's just off the coast of Somalia. I make this point because the newborn vitamin A issue is an example where region matters. That in the trials in South Asia, they have all shown a positive effect. And I'll show you that in a second and explain one other. And in Africa, they have not. And so the differences lie in risk factors, in the habitat, in the levels of deficiency. We should not expect the same effect throughout the world, automatically at least, from an intervention. And so it took 3.5, 4 years for the investigators to be brought together at WHO and have interactions that led finally to a paper that combined the evidence from 5 trials in South Asia and ultimately 6 trials in Africa looking at newborn vitamin A, neonatal vitamin A on infant mortality. And here is the summary of these trials. Stratified by South Asia, where there was a significant 13 and consistent 13% reduction in mortality. You'll see one study there by Sufi et al. That Zulfi was a co-author on that does not show an impact. However, I'd point out that the intervention was carried out by lady health workers who did visit these infants at 72 hours and at 1 week and at 28 days and every month thereafter through 6 months of age. And one would expect treatments to be rendered to these children where perhaps that care will nullify the effect on mortality. There was these are not significant differences, but all the odds ratios for morbidity in the previous 30 days that was collected was preventive, was protective with the group that received the vitamin A. In Africa, there was no effect. There was null effect across all those trials. And so the conclusions that the investigators that came out in this paper were that newborn vitamin A reduced infant mortality in South Asia, where maternal vitamin A deficiency, the prevalence of maternal vitamin A deficiency is moderate to severe, meaning prevalence of it, and infant mortality is high. But it had no beneficial effect where in Africa, where the context is different and where the prevalence of maternal vitamin A deficiency is lower and infant mortality lower. There was, I don't have a slide here, but Zulfi will remember, there was a Cochrane analysis that was carried out that led to a conclusion of no effect of newborn vitamin A. And so that opinion carried over into WHO recommendation that neonatal vitamin A does not reduce infant morbidity or mortality. And some remarks that I consider, with all respect to my colleagues at WHO and those who contributed to these comments, that are not clear, that do not help clarify what would be considered a galvanizing opportunity for South Asia to reduce infant mortality, where it can be estimated that some 160 to 180,000 infant lives can be saved every year in South Asia with 8 drops of oil with vitamin A in it given to a newborn. And there is no program today. Trials over 20 years in the making, and there is no program anywhere in the world today where newborns are given vitamin A. And there's where we sit. So this is an example where I would offer should be a regional recommendation. Dose the newborns with vitamin A to reduce infant mortality in Southern Asia. Don't do it in Africa. A final example relates to the multiple micronutrient supplement, the UNIMAP supplement. I had the pleasure of being in this UNICEF meeting in 1997, where we sat in the UNICEF headquarters, and the task was to come up with a multiple micronutrient supplement. And we got fed very well under the door, and we weren't allowed to leave. And finally, there was smoke that came out of the chimney, and we had a supplement. And it looked very much like the RDAs and the RNIs for micronutrients. The dietary reference intakes weren't out at this point in time, but it became the UNIMAP supplement. It's the supplement that got tested by and large, and it has become the micronutrient supplement providing an RDA roughly to women in pregnancy. And it's aimed at micronutrient deficiencies in women. And this was a paper by Bourassa that came out just last year, pulling the regions together, looking at the deficiencies that exist in women during pregnancy. And the only word that you can call here, relate this to, is sparse. Those dots are where there's less than 3 countries that have the data represented in that bar. And so there's only a couple of conclusions that you can make, that the deficiencies are there, but the more you look, the more you find, and what you find is not the same. And you can be assured that there are more deficiencies that exist than what is being measured, which is a statement also about the our inability over the past 30 years since the Ending Hidden Hunger conference in Montreal. It's a statement that we've not yet revealed hidden hunger. We are still dealing with a situation where we measure it very poorly. Fortunately, we have a micronutrient supplement that has been tested that at least gives a recommended dietary allowance of 15 nutrients to women during pregnancy, and that's been tested throughout Southeast Asia, South Asia, a study in China, and trials in at least Central West Africa to look at this issue. And there have been the Cochrane reviews and the meta-analyses that have been carried out that have that are showing favorable effects of this multiple micronutrient supplement. There are some regional differences. There are some effects that are seen in one area of the world, but not others. And that can be expected where habitat changes, where the diet is different, where the burden of predominant burden of morbidity and disease.
Keith, just 2 minutes, please, and then if that's okay.
That's all I have. In fact, I have exactly 2 minutes left, where we find this kind of consistency. WHO recommendation that has recently come out is favorable toward multiple micronutrient supplements, but it's in a context of research. And again, with all respect to my colleagues who and the committees that gathered and put their efforts into making the statement, it's not helpful in terms of a clear statement. It is positive, but it could have been a galvanizing comment and commentary about going forward. It could have said an antenatal supplement that meets a daily requirement of essential nutrients is recommended where the problem exists. And implementation research should be done to make the programs better. And that there should be antenatal care combined with this intervention to help keep pregnancies safe. And for those who are concerned about anemia for many different causes, that should be guided by healthcare professionals. And so this is a simplistic triangle that reflects the need to do the biology, the nurture, the disease research, the public health concern that arises from it, the interactions that go on, and that we still are looking to make clear statements about prevention, and RCTs play a critical role in that process. Thank you for your time.
Thank you very much, Prof. West. That was a fantastic overview, and I think the audience would have found that really valuable. Now, we have time for 5 minutes of rebuttal each, and then we will throw to Lynette. We have about half an hour left in the session or so. So 5 minutes, I'll start with Prof. Butta to rebut or to complement the comments made by Dr. West.
So I agree, this was a fantastic contribution, Keith, and I don't want to rebut any element of that except to say that I do think, and you didn't say too much about this, that trials which are done in real life settings with real life programs and that have all the nuances of what you saw in the neonatal vitamin A trial in Pakistan are probably closer to the truth than pure randomized controlled trials. So I think there are two stages in trials and two stages in the evidence synthesis from those trials. The first are the proof of principle studies, studies which are largely well-designed efficacy trials looking at mechanisms, looking at impact on outcomes, health and morbidity outcomes, mortality. But then a step beyond that is really trials that help you implement things. And they have to be implemented in the noisy world of today, in the noisy world of programs where health workers will do what they will do, while communities will do what they will do. I mean, one of the problems with iron supplementation trials is that in the hands of trialists, you can get compliance rates of 80, 90%. The moment you step aside and you give iron sulfate in real life health systems, you seldom get coverage rates of more than 20, 30%. So I do think, therefore, there is value in moving forward in evaluating effectiveness studies and programmatic implementations. I do want to say also something about whether or not we should include in the mix of systematic reviews programmatic evaluations or complex evaluations that come from maybe not pure randomized controlled trials, but larger implementations with quasi-experimental evaluations within them. That's a very important question. And I think for something like vitamin A, maybe the DEVTA trial was not the right design to answer those questions because the subsample for mortality estimation was indeed small. On the other hand, for something like worm impacts, it could have been appropriate just given the prevalence rates of things. So I do think that there is room in our wider evidence field or systematic reviews to have reviews that have both the pure RCTs, the cluster RCTs, and the noisy program evaluations, which have quasi-experimental designs. And that's the beauty of what we do in the Campbell Library, is we bring in the diversity of that experience and try to get to much more what Angus Deaton was calling for, is not only know what works from the pure randomistas, but actually see what works in real life and what makes things work and what will make a difference to people and programs. Thank you. I'll return some of my time to the Q&A.
Thanks, Dr. Butta. So what do you think of yourself as a randomista? Now, what I'll do is, Prof. West, I might just ask if you could comment in 2 minutes, and then because I'd like to make sure there's enough time for Lynette and the Q&A.
Maybe even 1 minute. I think I would just emphasize, though, Zulfi, that these RCTs, these community trials, are done in real life. They are done in real circumstances. The only difference is that the care of a design and execution are ramped up in order to provide this upper limit of it's really an upper limit of effectiveness for programs. It's the target toward which we strive. And I would add that the trials largely are done, should be done in areas where the need where the need exists. And so doing a trial in what might be called a resonant population that resonates with the risk factors and the culture and the programs and the resources and the climate and the food system and so forth, where you want to make a statement. When that is done with a feasible intervention using usually staff that are trained right from the community, it is a real life outcome in a real life situation that can lead to ramping up programs. And I will stop right there.
Well, Keith, if I may, Santa, with your permission, just say, yes, of course, if it was done that way, but you know yourself that at least one of the neonatal vitamin A trials was done in a circumstance where there was no maternal vitamin A deficiency. In fact, one of the most negative of maternal vitamin A supplementation trials was done in the same country. So I think in the context that we do these studies in, and I know of large cluster randomized trials of cord chlorhexidine that were done in settings where the majority of births are in facilities. So you could easily do a trial in the wrong setting where you're not really set to answer that question. So I do think effectiveness trials have to be done in the right context. And there is the real issue. I think, Keith, you might have said this in a slightly different way, of ensuring that in keeping the purity of trials, that you don't create an artificial context that is very different from real life. And I'll stop with an example of WASH studies. These large, mega $1 million of investment in water sanitation hygiene interventions that eventually end up by saying it doesn't work. Well, when you look at real life programmatic evaluations, real life studies such as the one that we will show on Wednesday, you see an effect of WASH because that's what you see in real life. But when you have an artificial situation of a trial where by standards of care and by the ethics of the trials, you have to provide a kind of care to your observed control community that may be much better than what they would have otherwise. Then you don't see an effect of it.
If just 1 second,
it's getting juicy, but I now that we're debating,
just one,
all right,
22
you've got 30
seconds,
seconds, and then I'll mute your microphone.
And that is about the program evaluation. I think what has happened with implementation science over the past, it's coherence, the coherence that is developing around that concept, and implementation research that is aimed at evidence-informed interventions. That's probably where the DEVTA trial, for example, should be sitting, and not in the efficacy trial bin. It really should have been, how can you make a program that has been shown to have an effect work better? And so I think we're going to see a lot of that in the future. I'll stop there. Thank you.
Thanks, Doctor. And just as you guys were getting the clause out, we had to just take a pause. But I would like to hand over now to Dr. Neufeld, who is represents an important stakeholder and in some ways consumer a lot of this information, to present her perspectives.
Hi, everyone. I'm just going to see if I can figure out how to make my slideshow work. There we go. I hope everyone can see that. Well, so that was a tour de force of evidence. So let's see if I can do any justice to trying to pull some key points out of this. And I think I would like to make 4 takeaway points based on what we've heard so far, and looking forward to continued debate after this. So the first point I would like to make is that policymakers need to have evidence synthesis to do their job. It's a critically important part of bringing evidence together. It's not enough to generate that evidence. We must synthesize it so that policymakers can use it and they can navigate the abundance of evidence and the sometimes contradictory evidence that exists. So the process that we're talking about here is fundamentally important. That process can be proved, but the process isn't broken. So let's not try to fix a broken process. Let's try to continually improve a process that has come a long way already in generating the kind of guidance that policymakers fundamentally need. One of the ways to improve that, which has been mentioned many times already, is to take better consideration and more consideration of the context in which we're working. We've known that for a long time, but we still don't do it well enough. We don't take context into consideration. We don't document context well enough in the research that we're doing, and it's time to move on and to do that better. But we also need to be careful with that context. What do we mean by context? One of the recommendations that we heard was to talk about regional guidance, but yet we know that there's still diversity within regions. There's still extremely great deal of diversity, even within countries. And so at what level, if we're going to look at going into guidance that goes beyond a global guidance to a regional or beyond even that, we still have to take into consideration the context. Context varies at every level, at national level, at regional level, and obviously at global level. So that is the one area where we can do much better in supporting policymakers to make guidance, to make policy. The second point I want to make is that just because you can measure it doesn't mean you should measure it. We have to go back to the principles of good design, whether we're designing an RCT, whether we're designing a systematic review, whatever study we're designing, go back to the fundamentals that we have all learned in good design. Consider biological plausibility, consider the potential to respond, understand the intended pathway to impact, and measure, understand, consider, and measure those intermediate outcomes along that pathway so that we can explain the findings, whether they be null findings, whether they be positive findings. We can look back and we can explain. It speaks to that question of using mixed methods, understanding the context in which we're working, measuring that context in which we're working in, and using the whole composite of all of that evidence to be able to make better conclusions. Select the outcomes to be measured on that basis, on that biological potential, that biological plausibility, and that potential to respond. And don't include others in the trial just because you can measure them, if the trial hasn't been designed to measure them and if it hasn't been powered to measure them. We've seen that in systematic reviews when I've been part of different processes looking at them. And if the outcome has been reported in a systematic review, or sorry, in a randomized control trial, it can be included in a systematic review. But perhaps that trial was never intended and it was never powered and it was never designed to have an impact on that particular outcome. And we need to be really careful that we haven't included studies in a systematic review that never had the potential to have an impact on those outcomes that we're looking at. Third, no one evidence synthesis method is ever going to reach meet every single need that we have. Micronutrient supplements lend themselves very well to randomized controlled trials and to systematic reviews. We're going to look at that in a moment in just in another slide. But as we heard in the opening session of the micronutrient forum today, as we try to address malnutrition in all its forms, as we try to address the double burden of malnutrition existing in multiple contexts, we're not always going to be able to randomize and have a single intervention that is the difference between our intervention group and our control group. That's not going to be feasible if we're looking, and particularly if we're looking at programmatic approaches. It's not going to be feasible to always have that one differential that we can look at and measure. And we need to start thinking about a broader diversity of evidence synthesis tools, evidence generation tools, and evidence synthesis tools that can add to our toolbox and ensure that we can measure the impact of the whole complexity of interventions that we need to address malnutrition. So we were told to make it as simple as possible, and this is going to edge on the side of oversimplification, but that's what happens when you are asked to comment in real time after a debate. So this was prepared in about 2 seconds, so clearly an oversimplification. When we're looking at randomized controlled trials and we're looking at that nutrient impact on a biological outcome, we can design a trial with a specific dose and a duration and the form of the nutrient and all of those other considerations. And we can take into consideration the age and sex and health status and diet. And as we're learning more and more, perhaps certain genetic circumstances that will lead to that. And if we're adequate in taking into consideration all of those contextual factors, we can look and we can measure that biological outcome directly. As we move and try to improve the quality of food that people are eating and look at the extent to which they are increasing their nutrient consumption, and then that leads to the biological outcome, it is going to get more and more complex. And our capacity, you saw that slide that Dr. Bhuta showed, the spider diagram of all the contextual factors that was at this level. As we start to move up and trying to improve the quality of the diet, and if we even think about the ways that we may try to improve the quality of diet through social protection, income generation, working in the food system to improve the availability and affordability of food, demand creation, and so forth, it's very clear that the randomized control trial and the systematic review of that isn't going to be enough for us to generate the guidance that policymakers need. And the fourth point I want to make is about our role as the scientific community. You saw that graph of the plethora of systematic reviews that have come out. There is a constant pressure to publish. There is an abundance of peer-reviewed journals, some of which may be having some questionable editorial processes. And it's fundamental as the scientific community that we don't give in to that publication pressure just to get that next systematic review because I need that one more publication on my CV. That's not the motivation to do another systematic review. Do another systematic review because there is a question that is valid to be answered. that the data and the studies exist to contribute to the evidence. Publish it in a good journal, in a reputable journal. Get it into the science. Why is that so important? It has a lot to do with the quality of the peer review. And that's a call not only to choose the right journal, but ultimately to us also as reviewers. It's fundamental that we do a good job and we catch those challenges that are there. We catch and we make sure that the people who are running these systematic reviews have read the small print, and that ultimately there will be better quality additional systematic reviews in the data. And with that, I will go back to the debate. Thank you.
Thank you very much, Dr. Neufeld. That was a fantastic overview and a wonderful call to action as well on that last slide. So in a moment, we will go across to our Q&A. So we have a number of questions that have come in. We have 13 minutes left in the session. So I think we should be able to do it. So it'd be great if I'll direct the questions maybe to individuals, but you can all chime in. But do remember, we'll probably get about 4 or 5 questions in, I think, in this time. So I'll get started. I'll start with a question to Dr. Butta. So the question is from Khalid, and it is that we know that social desirability biases are increasing even in the developed world. How do we address these biases in perception-based randomized controlled trials, particularly randomized KAP studies? This situation is becoming more alarming during COVID due to social distancing related error and remote use of social media. So I think the summary of this question is, are RCTs in social research becoming questionable, and can you think of an alternative?
Very good question. And I think it was partly the reason why I showed that absolutely fantastic thought piece by Naila Kabir. So RCTs in social sciences or qualitative studies that are based on just simple responses from respondents face the same kind of dubious relevance as do some questions within DHS surveys, where you get the kind of answers that you expect. So I think there is much to be said for mixed methods, and mixed methods where you have ethnographic studies, where you have qualitative studies nested within evaluations, where in addition to quantitative data, you have something else that helps you understand if the direction of travel and also how different people travel different way works the same. And those poverty evaluation studies in Bangladesh and Pakistan are examples, very recent examples, where if you just took the quantitative analysis into account, you got a different answer than once you had the qualitative studies layered on top, and you found that a number of people did not react the same way as you expected, did not respond to the stimulus the same way, and their agency or empowerment as part of that intervention was very different. So to answer that question, we need more mixed methods, and we certainly should not rely upon methods which are flawed in terms of the way those data are captured.
Would anyone else like to weigh in, or shall I go on to the next question? All right, I might. So the next question, I guess I might guess who the questioner is, but Catherine D would like to just ask, what would you agree that exploring heterogeneity via an IPD analysis of RCTs can provide the best of both worlds? She gives an example on the LNS example, which is being presented later in the forum. But for now, does anyone, maybe I'll ask Keith about your views on IPD meta-analysis and looking at heterogeneity as a potential way to look for context.
Oh, I think that this must be Catherine Dewey. Kay, I mean, I would say that this is the way forward. I think understanding the sources of heterogeneity and looking at it and collecting the data that's needed to address that and understand it by not only region or country, but by specific demographic as well, and disease group is all going to help us better design these programs. And so I think it's the way forward. It is the level of complexity in which we need to work in order to understand how to, again, this is for me, this session is about how to drive policy through our research. We have to understand that heterogeneity that can help us to explain under what conditions and what effects may be expected through a particular intervention.
So, Santa, if I may add, so Kay, as you know, we've dabbled in a bunch of recent IPD analyses. Some of them have related to multiple micronutrients, and Keith, you were part of that particular exercise. Others have looked at other interventions, deworming, I've just gave you an example for other health interventions. With LNS, and I'm really looking forward to your paper soon, I think it will be a major addition to the Cochrane reviews that have been done on the subject, because they're all relatively recent studies. So I think relatively recent, well-designed studies with scientific validity are strengthened enormously by an IPD, particularly if you have a prospective IPD plan where you have some of the questions written a priori and studies designed to be able to contribute to this. To give you an example, we've just published a very large series of cluster randomized trials across 4 countries as an IPD in the Lancet. All the individual studies were published separately, but the IPD was placed in the Lancet because it was accumulation of a lot of information collected with a level of standardization and with a level of control in terms of how those information were put together. That may not be possible for studies that span a longer interval and with diverse groups. So I increasingly worry about IPDs also attempting to try and do what we attempted to do in our deworming studies, is to bring in various aspects in the context that may not just be possible from the studies in themselves, such as, for example, the governance of the local environment, the health or nutrition environment, such as issues that may relate to population mobility, which was a case in many of these studies. And I think, therefore, the creation of what is truly a synthetic cohort as part of an IPD, as you put everything together and you begin to see it, particularly in a one-step IPD process, may have scientific challenges when it comes to studies dispersed across a longer time interval. But I fundamentally agree with you that as we design these large randomized controlled trials, particularly multi-country trials, that we increasingly ought to take into account the potential that we may be able to do an IPD together. And it'll have 2 advantages. First, better design. Secondly, rapidity. As Keith said, it's taken years to get an IPD on neonatal vitamin A together because it was done post hoc. The same is the case with the cord chlorhexidine studies, because it was never designed a priori to do this. It has still not come out because that analysis has taken such a long period of time. So I think moving forward, we probably ought to make this a part of the original trial registration, particularly for multi-center studies where you have common funders. Over.
I might ask Lynette to I'm just going to extend on that point and just hand it over to Lynette, which is, do you think then that there's a role, for example, could it even be the MNF, Micronutrient Forum, or other groups to establish networks and core outcome data sets for these sort of trials that would facilitate both networking of the investigators so that the trials are done in some sort of coherence, even by disparate groups? And secondly, at the very least, having formulations of core outcome data sets that enable IPD to be done instead of just individual investigators dreaming up their own related but not identical outcomes.
Yeah, I think this can address a lot of the challenge that we face, right? You talked about making sure that we have access to the data and having networks or consortiums or collaborations up front at the moment of design, ensuring that you're looking at common indicators. We didn't talk too much about that, right? But in some cases, one of the challenges that we have is even even using variations of the indicators that we're measuring and non-comparability of outcomes. So yes, I think having some kind of a consortium can go a long way towards preparing for IPD type and ensuring that yes, the measures are taken, the quality is assured. It doesn't avoid all of the challenges that we were just talking about, right? You still have to think about the quality of design and so forth, but having a system set up that can set the standards and that can be a quality check towards the compliance with those standards would definitely be a support.
Great. We just have a couple more questions left. So there's another question about heterogeneity from Susan, and I'll hand this again to Lynette as a consumer or as a user of data, which is really, there's many ways to think about heterogeneity, but at the end of the day, there's a lot of different systematic reviews. There's many examples of systematic reviews that come to different or different conclusions about the same question. And I know, Lynette, you've been involved in a lot of policy work at WHO and also in GAIN. So what do you do if you start seeing different results from the same question from systematic reviews?
Well, I think personally, I do exactly what I think it was Keith, if I'm not mistaken, recommended. And I go back and look at the research. I look at, well, first of all, I guess you start with the systematic review itself, look at those criteria, read the small print, go into the online supplementary material and figure out what it is that they actually did in those systematic reviews. Then you need to sometimes go back and truly understand the context in which those trials were done. So it takes time, it's a lot of reading, but there is no way around it. If we don't pay attention to those details, there's no way to come to some kind of a conclusion about how to move forward. That's from my personal opinion, my personal perspective, and how you go forward. In a policy process, this is exactly the challenge that we face. Because, I can come to a conclusion personally from there. I can go speak to a government, and then Keith, comes to a different conclusion with that evidence. And next time there's a consultative process, he's there. We may be providing different technical advice. So again, I think this is another good role for the Micronutrient Forum for us to help navigate that process and help document the differences and essentially the reasons and that may be coming to different conclusions, and helping guide forward a narrative so that people can navigate that. It's a big challenge. No easy answer to that one.
Thank you very much for that. So I think I'm going to bring us in on time. It's 1 minute to the end of the session. So I'd just like to firstly thank the Micronutrient Forum for hosting and allowing us to have this session today. I hope that the audience has found it valuable. I've found it valuable to really dig into the way that we think and the way we come to our conclusions, and in a way it's even our belief systems around some of the interventions that we give, and what digging into what the assumptions and the structures and the bricks and mortar that make up those beliefs. Of course, I'd really like to thank Prof. Buta, Prof. West, and Lynette Neufeld, fantastic speakers, fantastic discussant, really covered a lot of territory, and I know that generously gave their time to prepare this session. So mostly I'd just really like to thank them for their contribution. I'm sure everyone's clapping at home. And I'd really like to thank the audience for enjoying, for coming along, and I hope being able to enjoy this session. And we'll see you at the next one. Thanks a lot.